Thank you. So welcome everyone to the Neonatal Justice Collaborative General Body meeting. We are super excited for today's presentations, but I'll start with a few announcements from the NJC generally, and then we'll launch into our plan for the day. So we have our NJC research works in progress meeting coming up in the first week of August. And it sounds like we still have room for speakers to sign up for that. And so if you're interested, please contact us. I can put up a QR code or a link a little bit later in the presentation, but that's the first week of August. For those who are subcommittee leaders, we actually have a core leadership meeting in mid-August, and then we have our Med Ed and Diversity Subcommittee meeting in September. And just wanted to say that for our fall in-person conference, we're still in the process of arranging and organizing that. And so just be aware that we'll let you know through the listserv when we've decided a plan for that, but we are still in the midst of working that out. And today we have a really exciting agenda. We have presentations from not one, not two, but 4 nursing leaders in neonatal health equity. And so they'll be speaking to us about 4 different projects of how they've advanced neonatal health equity in their respective geographical areas. And so our nursing colleagues are coming from Massachusetts, Michigan, and Washington, D.C. today. And we're so excited to be able to showcase the great work that they've done. And so I'll introduce each speaker and their presentation will follow. The flavor of this is really back-to-back presentations. So everyone has a chance to speak and isn't cut off and is really like getting the flavor or exposure to what folks are doing with the hope of being able to, reach out to them or hear more about their work in detail after hearing the flavor of their work today. And so all speakers will, present back to back to back. And so there won't be a Q&A after each presentation. If you have a question that comes up, please drop it in the chat. And so speakers will feel free to answer those Q&A via the chat function, during the other presentations. If it's like a quick clarification or something that you can answer via text. Otherwise, we'll circle back to longer questions during the verbal Q&A at the very end of the set of presentations. So without further ado, I'm going to stop sharing and we'll start with our very first speaker, Dr. Ashley Darcy Mahoney, who can start sharing her screen. We are really excited to welcome Ashley, who's a professor, neonatal nurse practitioner, research and educator at George Washington University in the School of Nursing. Her program of research aims to enhance early childhood outcomes, especially in language interventions to promote future literacy and cognitive development. And so she played a key role in conceptualizing and launching Talk With Me Baby, or Habla Me Bebe, which is a app that utilizes nurses to empower parents with knowledge about the critical role of early language and in predicting academic success. And so we are really excited for her to present to us about that project today. And so without further ado, I'll let her take it away.
Great. Hi, everyone. How are you? I'm actually not going to use slides. I'm going to talk for a few minutes and then show you all of video. I think there's a million ways to do this, and this is one. So I'm going to give you guys a little bit of sense about what we did and what I've been doing. So I'm Ashley Darcy Mahoney. I am a nurse practitioner at Nicholas Children's Hospital and also a professor at GW. Prior to my time at GW, I was at Emory, and in 2014, we launched a program called Talk With Me Baby. And Talk With Me Baby was a public-private partnership that we did with the state of Georgia, WIC, Emory School of Nursing, Emory School of Medicine, Department of Peds, and the Marcus Autism Center and other colleagues in the area in education. And we really were focused on what the Commissioner of Health at the time wanted to was really build early brain development from 0 to 1. And our focus was essentially getting nurses to teach parents that talking to your baby is important. And we did that really with the idea kind of similar to back to sleep, like how can we get the message out to really trusted messengers out to parents? And that was when we launched. So we launched about a decade ago. We got really interesting and unique funding sources, which I'm happy to talk about through both public and private foundations and grants. And as we started rolling this out over the many years, we started getting lots of requests for, you know, how can we assist our families that speak different languages? I'm from Miami. I take care of babies in Miami. And so felt really strongly to try to think about how we can use, how we can work with families that speak Spanish. And so what we did then was partner with a linguist here in Miami and a developmental psychologist to come up with a program, technology called Háblame Bebé. And so that's what I'm going to talk about today. But I think the early beginnings of where we came from with Talk With Me Baby inform some of this work. So one of the strongest predictors of successful language acquisition and later academic success is the quantity and quality of words spoken to a child from 0 to 3. The thing I get most often when I give this talk in various medical areas and nursing areas is like, why do we care about this? And so education and health are intimately intertwined. And as the pediatric folks in the room, right, I think we know that more than anything else, but understanding that link between health and education is something that I've always sort of brought forward when I give this talk, that it's incredibly important for us to understand the stuff we do in the beginning of life affects the stuff that happens to kids and then affects their lifelong health. And one of those things is language, and conversational turns between children and their adult caregivers has been associated with greater brain activation in neural systems. Some great work that's happened in Rhode Island has shown that over and over. And we know that language processing and the difference in the activation that happens with this interaction with families and kids is important. And it plays a really important impact on literacy skills and child vocabulary. Specifically, child vocabulary at age 3 is a significant predictor of grade level reading at 3rd grade, which has lots of later predictions that we can talk about whether, you know, those are right or wrong, but grade level reading at 3rd grade is incredibly important for kids' later academic success. And to address some of this really important, you know, gap that sometimes we see, or opportunity gap that we see, there were a lot of public health initiatives put into place. So some of them you may know, Providence Talks was one, Reach Out and Read, which many of you probably know, TMW project in Chicago, Too Small to Fail, Talking is Teaching, right? The list sort of goes on. And so what our team did in 2016, the HRSA came out with something called a challenge grant. And for those of you interested in getting funding, challenge.gov is a really interesting place to go. It's not like your typical grant mechanism. It's a lot more like Shark Tank, which I didn't know because I've never done Shark Tank. But what I learned was that you go and you sort of write a typical grant, and then you go to HRSA and you pitch your idea in 8 minutes. And you say, like, this is what I'm going to do. And then they give you this like tiny amount of money, and you go and you try and do your project. And that's what we did with Háblame Bebé. And we went to families and we said, here's the app that we created, this like beta version that was web-based. And it wasn't any that good. And it was just like good enough for $10,000. And we went and we tested it with a lot of families. And then they said, yeah, this was good, but not great. Do all these things. So then we went back to her. So we said we did this, and they gave us like $20,000. And we were like, okay, we'll try to make this a little better. And then we pitched it to like a lot of more important people. And then they gave us a lot more money to actually go and create an app. And what we know is that what we found from our literature and literature of others is that Hispanic Spanish-speaking parents are often made to believe that they must switch to their non-native English as a result of fear-based rhetoric, linguistic racism, English-only policies, assimilation pressures, misinformed advice, which can affect a child's early language environments. And I've partnered with a linguist in this effort, and she's given me like a lot of more verbiage to be able to say some of this, but encouraging families to use their heritage language will convey more lexically and syntactically complex language interactions, right? That happens as you're speaking to a baby or a little one in what you know to be true. And that's what we did with Háblame Bebé, is we went back and talked to families about how and what they needed to know in an app, in a technology, to be able to talk with their babies. And what we went back and forth with families a lot, and what they told us a lot, is that they experienced this kind of linguistic racism. And what they wanted was a message of, let of like hope, and recémonos is how you would say it, like this message of let's get in touch with our roots, let's be proud of our heritage and not feel badly about talking in this language. And so we started implementing a lot of that work into our app. We have people that speak various dialects of Spanish from a lot of different places within the app to show parents how to do it. And for many years, we worked in doing this. And so in Miami-Dade County, we partnered with Nurse Family Partnership, with the public library system, and others to be able to create this app. We've gotten really great funding from the NIH and from HRSA and from a lot of other partners in this effort to really bring this idea that early brain development matters. Parents are their child's first and best teachers, and teaching those kiddos early in your home language will lead to better reading outcomes later. And I'm going to show you a video of sort of, I think, how we've done that, how we've shown that. And I will sort of just wrap to tell you that Habla Bebe is available to you all, whether you have Google or Android or Apple device. It's free to download. We have about, I don't know, 15,000 users. It's on every device, all 7,000 tablets in the Miami Public Library system, and it's part of Nurse Family Partnership down here in Miami and hopefully other places soon. So I'm going to wrap there so that I make sure I give everyone their time, and I'm going to show you this video and then take questions at the end. So hopefully that gives you like a sense of what we're doing here.
Háblame Bebé is a free educational technology application aimed for parents of children 0 to 3. The goal of the app is to promote bilingualism, ensure that developmental milestones are met, and really promote sociolinguistic pride among families.
Sociolinguistic pride can be defined as the pride to be Hispanic and to speak Spanish, to raise your child bilingually and to keep that Spanish up. Unfortunately, there are a lot of myths that surround bilingualism in this country, and I think the biggest one is this notion that bilingualism might cause a delay, whether in language development or cognition in a child, and that's absolutely not true. On the contrary, science shows otherwise, that there are several benefits to bilingualism.
Health and education are intimately intertwined. 85% of brain development happens in the first 3 years of life. By using Háblame Bebé, we can ensure that families know what the developmental milestones are. We want to ensure that a child is meeting those developmental milestones so that we can intervene early and act when necessary.
En los hitos del desarrollo nos dice que el niño tiene que tener dos palabras juntas, es decir, mamá quiero, mamá dame, mamá tengo, mamá más. Y mi hijo no lo decía. Ahora que yo veo la aplicación, me doy cuenta de que sí había un retraso en el habla, y es una de las señales que nos dan a nosotras como mamás latinas. ¿Quieres decirlos en inglés?
5,
Ajá.
6,
Ajá.
7.
We decided to apply for the National Library of Medicine funding because we wanted to infuse the app with several more resources that were video and audio based for families, and also include some incentivization like a gaming component. Parents earn hearts based off of the activities that they do in the app, and I think especially add a component, an entire partnership with the public library system.
Our library loves Háblame Bebé, that app. So we have it in our 700 tablets. It's downloaded in there, and libraries are our information hubs, and so we're happy to help our communities that way.
The National Library of Medicine research grant mechanism is, in my opinion, the most important way to get science and research that's being done into the hands of families and parents. And it allows us to create projects that directly translate that science into everyday practical strategies that we can do to promote health.
Háblame Bebé es un apoyo para nosotras las mamás latinas de habla hispana. A veces nuestro estatus no nos permite tener recursos como de terapias, seguros, entonces se nos dificulta y nos da miedo pedir ayuda. La aplicación Háblame Bebé nos da este apoyo que necesitamos, cómo ir desarrollando a nuestros niños de la manera correcta.
Thank you so much, Ashley, for that wonderful presentation and, showing us about this amazing project where like my first burning question was like, how do we use it? So thanks for answering that question off the bat. And we're really excited. I mean, thinking about how you can use this type of app in our setting, in our like neonatal nursing nurseries and our NICUs is really an important like beginning step for all of us to be able to use. So thank you so much for your work and providing us with the grant funding information as well, which is, you know, a very necessary part of it. So thank
Sure,
you
I'll put a
for
bunch of
sharing.
stuff in the chat for you.
Great. So we will move to our next presentation. Stephanie Adam is the nurse manager of a 55-bed NICU and continuing care nurseries at Bay State Children's Hospital, which is an academic hospital in Western Massachusetts. And she has 35 years of NICU nursing experience and has expertise in lean methodology. And so she's led teams to have success on a number of QI benchmarks in her hospital. Is really exciting to read her CV with so many successes to share. And we're really thrilled to hear about her efforts to identify and reduce safety disparities. So thank you, Stephanie, for teaching us. I think you are still muted.
There we go. Let's try it now. Again, we should know Zoom by now. Thank you for having me. I really appreciate being here. This is such a great forum. So what I wanted to introduce you to was my journey with Solutions for Patient Safety on collecting outcomes-based data based on race, ethnicity, and language. I think people, I don't know if you're familiar with Solutions for Patient Safety, but it's a network of 140 hospitals across the world that are all working to create zero harm in our patient populations. But they've recently asked us to start collecting our CLABSI and unplanned extubation data along with race, ethnicity, and language data so that we can see if there are any potential disparities and prevent future harm. So when we started taking a look at how we were going to collect this information, we realized we had a lot of hurdles. Our patient registration process collected mom's data, but not baby's data. And essentially, our mother's data crossed over to the baby's chart, and it was never updated. So it only captured mom's race and ethnicity. It really did not capture any of dad's race, ethnicity, or language information. So we knew we had a problem right off the start. And we also learned in our institution that once the race and ethnicity data was collected, it wasn't asked for again anywhere in our system. So it wasn't uncommon for babies to be born given a race, ethnicity data and have that data throughout their lifespan here in the Western Mass. And then we figured, we were wondering how are we going to collect this data? Should it be from the NICU? But then we realized that it would only be NICU babies that had the correct data. And we really wanted our data to be accurate in order to be meaningful. So we had some work to do. So essentially, we considered different opportunities to collect this data, either through the birth certificate, social worker, patient reg. But we really came down to is that our LDRP nurses, they're really uniquely positioned to create a safe environment for collecting this sensitive data. And this data needs to be collected in a way that preserves a person's dignity and encourages them to feel safe to share. I, along with some of my colleagues, worked with SPS's Real Data Collection Resource Assembly, and part of that, we did an extensive literature review and reached out to other hospitals to help understand how to collect this information. We surely learned an awful lot of information, which we then shared with our LDRP team to understand why this work is so important. We realized that people in communities have concerns about how this information is collected and how it will be used. And that's why scripting this conversation can be so helpful in order to maintain the respect and decrease people's fear as you're collecting the information. So why should we do this? It's a no-brainer, of course, and I'm preaching to the choir here. But many of our most trusted hospital resources, AHRQ, CDC, IOM, and there's many others, they've identified the problem of disparities in healthcare. And although it's uncomfortable to think that our own implicit and explicit biases impact our care, it really is our reality. We know it's happening. I've seen the data in my area and know that we have problems right within this hospital. But one of the things that I have found as a manager over time is that data drives action. If you can show people the data, it helps them to better understand that, you know, even though they're not trying to have problems with bias, they may be having problems nonetheless. So collecting this data will definitely help us identify where the disparities exist so that they can be addressed. Help us to understand that there are barriers in our community that our families face in terms of accessing care. And it allows for resources to be deployed so that we can get the needed results that are required. So some of the concerns that we learned about in doing this literature review, we needed to share with our team. So they needed to know that when they're collecting this data, they had to be able to speak about how the hospital was going to use this information. And the scripting would help alleviate any fear that this data may be used to discriminate or deny care. So the major places where families had concerns about this data collection was who had access to this data. How will my data be used? And will this affect the quality of my care? And also people, according to my research, they wanted to see their nationality, their ethnicity identified on that hospital list. So some other important information to share if you're collecting this data is that it should be accurate and self-identified. The data should be complete. Avoid using other and unknown as an easy way out. Create an environment where it's comfortable for people to respond. Ensure that you're using the patient's preferred language to collect this data. And do observations of staff collecting the data to ensure the quality of these interactions. Provide the scripting and stay up to date on your national standards. So we collaborated with many people throughout the LDRP and the NICU. We added these race and ethnicity questions to our intake interview form, and we performed these questions. We asked these questions while we were ruling out domestic violence, because that was a time when we were creating a safe space for our families to open up to us anyway. And again, there's nothing like that LDRP nurse who's making that really special connection with a mother as they're going through kind of one of their most momentous journeys in their life, right? So it really had worked out well to have these LDRP nurses collecting the data. The OA, which is our unit secretaries, would then use the form that the LDRP nurse used to collect the data, and they would enter that information into the baby's chart. We had general staff training, and we created some additional Zoom training with job aids for our OAs, our secretaries, so they knew how to input the data correctly. So here I'm just sharing our script, our basic script, and we have a few different charts that we use in conjunction with this.
Stephanie, we have like 1 minute left.
Perfect. I'm just about done. So essentially, we have about 176 options for identifying race and 17 options for identifying ethnicity. It's validating for patients, like I said before, to have accurate options to identify themselves. And the other thing that's important is that your community base changes over time. So be prepared to look at your community statistics and make sure you're updating the options in your chart for our families. So as we're looking at identifying discrimination for CLABSI and unplanned extubation, those are outcome measures. But what we really need to do is take a look at what are the differences in the way we are providing our care bundles and how are they applied maybe differently in populations at risk, and look at the process that we're providing the care. I would encourage people to engage families to help us find solutions with the overall goals to ensure that our safety processes are applied to every patient every time.
Thank you, Stephanie. That was an excellent presentation. I mean, that's such a common problem for all of us, like hospital variation in collecting data to even start our QI projects that are equity focused. And so really appreciate you sharing with us like such a thoughtful plan from the outset that led to such a thoughtful workflow at the end. You know, really doing this in like a very specific and comprehensive way is super important. And so really appreciate you sharing your script and the details of how to implement a data collection change like that. So again, reminder for anyone to drop Q&A questions in the chat, and we'll get to them as we continue our presentations in the chat and then verbally afterwards. And I will start introducing Monica Germain, who is a nurse health equity professional who recently completed her Raven Davidoff Equity Fellowship at Boston Medical Center. She's also the chair of nursing DEI council at the Boston Medical Center. She's won several awards in nursing and diversity in healthcare, and she's very active in recruiting and retaining minoritized people to nursing and leadership opportunities. And so today she'll be describing that important work to diversify the nursing workforce. So really excited to have her.
I want to say thank you for having me. And I have worked with adults all my life. I've had a nephew that was in the NICU. He was 26 weeks and 4 days. So kudos to everyone that is a NICU nurse or works with pediatric patients. I commend you all. Just want to say thank you for having me in this space. Let's see. Let me share my screen.
Monica, while you're sharing your screen, thank you for dealing with adults so we don't have to.
Amen.
And I just want to say I'm representing Donna Stickney, who is the NICU nurse manager at Boston Medical Center. So I'm just representing Donna Stickney. Okay, so hi everyone, my name is Monica Germain, and I'll be talking
Monica,
about...
we're seeing your presenter mode, just so you know.
Oh no, that's not supposed to be right. Hold on.
Looks great.
Still seeing it or no?
No, it looks good.
Okay, awesome. Okay, so my name is Monica Germain, and I'll be talking about diversifying the nursing workforce. Quick overview, I'll just go over introduction, over the NICU overview, the NICU equity lens, and then what we do as Boston Medical Center as a whole. I think Kayla did a quick introduction, excuse me. So my name is Monica Germain, nurse health equity professional at Boston Medical Center. I grew up here in the city of Boston. My nursing career has been around historically marginalized populations throughout my 10-year nursing career. Community health, federally qualified healthcare center. I've even worked in a correctional facility. It's not as bad as people think it is. And I racialize as Black and ethnically Haitian. So overview of the NICU at Boston Medical Center. So it's a 21-bed neonatal ICU with beds that include level 2 and level 3. So our BMC population is racially and ethnically diverse, with about 40 to 50% of our patients identifying as Black or Hispanic. So the question came about of how do we increase our diversity in the nursing staff, because historically nursing overall is predominantly white. So one of the things that Donna started to do is looking at the job description through a health equity lens. On the left-hand side, you can see that this is one of our new grad programs, and one of the job description, it says senior practicum required in the NICU. So one of the things that we started to, well, Boston Medical Center started to do as a whole is removing that practicum. We know that all nursing schools do not offer senior practicums, and all nursing schools are not made equally. And access to a senior practicum, lack of access to a senior practicum in the NICU can exacerbate disparities in job opportunities among nursing graduates. Students from schools without NICU placements may face additional barriers in entering this school's specialized field compared to peers from schools offering such practicums. For example, associate degree nurses don't usually get a practicum. I started my degree from associate degree, and I did not get a practicum, so eliminating that. Next in the equity lens is bilingual preferred. So asking, putting in our job description that bilingual candidates are encouraged to apply. So at Boston Medical Center, our top 3 languages that's spoken are Haitian Creole, Spanish, Portuguese Creole, and Cape Verdean Creole. So again, that is casting a wider net for a more diverse pool. And it's meeting the needs of our community. You know, our facility serves a diverse population with varying language preferences, and hiring bilingual staff ensure that these facilities can effectively meet the linguistic needs of the communities and fostering trust and accessibility in healthcare services. As Boston Medical Center as a whole, we do have a DEI nursing council that began last year. That is, I guess, hospital-wide and has different nurses from different areas, including the NICU, L&D. This is our mission council and statement. I'll just leave it up for a quick second. It's kind of long to read. I'll read the bottom half. So the Nursing Diversity, Equity, and Inclusion Council provides support for the development and implementation of diversity and equity inclusion initiatives within nursing department at Boston Medical Center, and works to foster a respectful, culturally appropriate environment for patients, families, and staff members. So the primary goal of this committee is to advance the strategic goal of supporting diversity, equity, and inclusion as being integral to the care of ourselves, our colleagues, our patients, and their families. And right now we're working on a 5-part health equity series that is entitled Understanding Disparities and Health Equity. I think a lot of nurses kind of miss the boat of understanding what health equity really means and how some of our patients are in the situations that they're in with no fault of their own. So educating the nurses on that. And then again, embracing and hiring practices, embracing diversity in hiring practices. These are some questions that are now included in our hiring practice that reflect BMC's mission and values. So how will you contribute to BMC's efforts to enhance diversity, equity, and inclusion in a meaningful way? In what way do you think diversity is important to someone in the role of nursing? And I can leave this up so you guys can read it, but including this in the process to kind of gauge a person's understanding, not that this is the end all, but just kind of gauging someone's interest and why they want to work at BMC, because we really do embed ourselves within the community. And then just to end, just practice intentionality, you know, tailor job descriptions, feedback, continuous improvement, and diversity metrics and goals. Our HR department does collect data regarding how we hire nurses. Unfortunately, I'm unable to share that data with you, but we do collect that data. And that is it. Thank you so much.
Thank you, Monica. That your work is so important, and you know, the NICU is, as we know, like a very traditionally homogenous place in terms of racial identities and language is spoken, and yet there's so much compelling data that a diverse workforce is better, not just in medicine, but in any workforce. And so, you know, thank you for sharing your process in actually changing a system. This is systems change, structural change, which is hard. Takes a lot of people, multidisciplinary effort and persistent effort to be able to change all the elements of a hiring practice. And so I'm sure many folks on the call would be interested in hearing more about how to do that in their institution. So kudos to you, and thank you for sharing.
Thank you so much.
So next we have Dr. Ashley Vance, who's an assistant scientist in the Center for Health Policy and Health Services Research at Henry Ford Health. She's also a research subcommittee leader at NJC, so you guys are probably familiar with her. She conducts research in health services, health equity, and economic outcomes associated with having a medically complex infant. And today she'll be describing work a little different from that, which is a plan to develop a nursing curriculum in health equity. So more of a nursing medical education topic, which proves that she does in fact do it all. So thank you, Ashley.
Thanks so much. Real excited to join this general body meeting and talk about this potentially this new work. So I do want to just have a caveat, or at least just start by saying that this is potentially going to be funded any day. Hopefully, it is not officially funded yet. So just kind of keep this information, you know, kind of your eyes only, this group only, but please feel free to reach out, and hopefully more will be forthcoming. But some colleagues and I at Henry Ford Health and Michigan State College of Nursing developed a grant proposal titled Nursing Program for Advancing Training in Health and Social Determinants, as we are affectionately calling it NPATHs. So, there we go. Okay, so a little bit of background as to why, we all know this health equity work is important, but it's really kind of come to the forefront of research and education in the last couple of years. And specifically, NINR published a new strategic plan that has called out specific research lenses that include health equity and social determinants of health, along with their population, community health, systems and models of care and prevention and health promotion. And so in alignment with their new strategic plan and these research lenses, there was a specific call for an R25 funding mechanism. An R25 is for to develop research education training programs. So smaller than like a traditional T32 or other programs, but it's a 3-year grant that to promote the development of educational programs, however you kind of want to envision that. And so this is to help kind of lift up the nursing community as well, to allow them to conduct health equity and social determinants of health focused research, especially as PhD or doctorally prepared or even advanced practice nurses are coming out of their programs, or maybe recent graduates where they may not have had a lot of this content built into their core curriculum. And so we're hoping that this then kind of becomes a supplement or an additional way for people who are interested in this information to seek it out. So part of the significance of why a nursing education program would be important is that we know that the research has shown that there are many, many non-medical factors that impact our physical and mental health. And these inequalities in healthcare are expensive to the healthcare system, and of course are disproportionately disadvantaging certain groups. And so, you know, within the nursing community and the medical community, we've really recognized that we're uniquely poised to help reshape this landscape of health equity from both a research and kind of clinician perspective. So we have devised 3 specific aims to conduct this work. Really, the first one is that overall goal is to develop or establish a research training program for nurse scientists. So even though this is a neonatal specific talk or group, this project is kind of for nurses and other allied health professions across specialties. Our goal is to really foster this collaboration and include these diverse perspectives among program participants. And then we really want to be able to develop this curriculum in such a format that for sustainability reasons, so that after, you know, the grant funding, you know, runs out, that we can continue to disseminate this knowledge and or seek additional funding to keep such a program like this alive. So what have we envisioned? So the NPATH program itself has three main objectives, which I have listed here. As you can see, is we really want to enhance the participant knowledge and understanding of specific social determinants of health frameworks and their concepts, strengthen their capacity to apply these concepts into their program of research. So again, this is going to be really focused on research training. And so thinking about how research is conducted at the bedside, observational studies within the community, and all those different spaces that it occurs. And then really to expand the volume and quality of nurse-led research-focused projects on health equity. And so then the specific components that we've envisioned for this work is to start out with an in-person intensive, as we're calling it, or a 3-day workshop that will really bring all of the participants together, hoping for about 8 to 10 participants in the first year. And that'll be a time where we're bringing in keynote speakers, having lectures. We've envisioned several community panels and potential visits with other community partners, specifically in the Detroit area. And to really just foster community building and collaboration. And so after the 3-day workshop that will occur, we have then proposed we'll be doing monthly learning modules. We have both asynchronous and synchronous learning that will be developed around specific content. And so the self-paced kind of asynchronous learning will occur at the participant's leisure, but will be reinforced by monthly talks or webinars with experts that are aligned with that month's learning. And then every participant will be paired with a mentor in order to really get that research, experiential research. And also be able to develop some type of research deliverable, whether that be a specific games page, maybe a full proposal, an abstract, a paper, some kind of deliverable that will also reinforce their own program of research and help them in their career path. This is our conceptual model that we developed for this grant, really using the World Health framework as well as the NINR strategic plan within each of those kind of buckets around social determinants of health. And so we've aligned our NPATH curriculum and the topics to make sure that we are bringing in topics that kind of cross each of the very specific kind of categories, whether from a community context and also the information that's specific to a healthcare system and what that looks like as we interact with our patients. So this is an example. Hopefully you can read this table well, but this was what we envisioned for that in-person intensive, and just kind of showing how we're hoping to structure those 3 days, potentially a 4th day, depending on what comes to fruition once we're able to schedule everything. But it's very much a combination of kind of some hands-on, group work, learning, discussion, as well as didactic information, keynotes, and again, bringing in community members to talk about specific issues, especially around food and water safety or housing. And then, as I mentioned, those monthly learning modules and webinars, this is just an example of what we've proposed for months 2 and 3. And we can just see that some of the top information is the stuff information for the self-paced learning, and then a webinar topic. So who are we looking for? So we are hoping to, as soon as kind of money comes in, hoping to hit the ground running with the development of a website, as well as an application, and really start disseminating the availability and the potential to get those who are potentially interested and encouraging them to apply. Part of the stipulation of the grant is for the 3 years that the workshop or program, whatever was proposed, needs to be hosted at least twice. So we would hope to host our first NPATHS program next summer, potentially starting next August or September. And so we'll be looking for 8 to 10 participants. There will be an application that we will ask people to submit. It is focused on those who have a nursing background, but we welcome anyone who also is in a healthcare field, but we do want people that are specifically interested in conducting research and or have that capacity kind of in their future career to be able to move this work forward. And with that, yeah, just this is a quote I will end on, just because part of research and education, you know, bringing awareness to the topic, but really as we center the voices of those at the margins, you know, I think we'll really be able to improve care for everyone. So thank you so much.
Thank you, Ashley. Really appreciate your talk. Again, like, really ambitious project. We talked about this before. This is like super amazing because, you know, it's like contributing to like increasing the capacity of our entire workforce to do this amazing health services, health equity research. And it's a lot to take on. So thank you for doing that. Curious I might start with one question directly related to what you're talking about we know that we think that the grant funding is coming in to support this project and the curriculum, you know, you will start enrolling folks, but so it's a little early to get in or apply, but how can folks reach you or hear from you later on if they're interested in this project?
Absolutely. So I'm going to just drop my email in the chat. That's going to be the best way to reach me specifically. And then I'm really hoping to potentially then have kind of like a bare bones website, maybe within a month or two, that I would be able to share that at least has general information about like what people can expect from the program, you know, kind of putting up a sample schedule, and then when we might open the call for applications. I anticipate that we would not be ready, or my timeline is I'm hoping that by January we would be able to start accepting applications, have the call open for a month or two with decisions early spring for then people to plan for late summer, early fall to participate, all kind of starting next year in 2025.
Great. When we have that information too, we'll certainly amplify it through the NJC listserv too.
Great.
So I'm going to go through a couple of Q&As in the chat, but feel free, anyone can raise their hand and jump in line too. I wanted to start with Stephanie's question, which I really enjoyed, to Ashley about this, the Háblame Bebé app, about like cell phones as being, you know, both a deterrence and maybe a tool for like, you know, communicating and interacting and engaging with individuals around you. And so curious, I know you answered a little bit about that, Ashley, in the chat, but curious your thoughts on, you know, tool versus obstacle.
Yeah, sure. So I think a lot of the work we've done with Talk With Me Baby and Háblame Bebé has been meeting people where they are. And I think we would be remiss if we said that our 18 to 35-year-old childbearing age, I use that loosely, I know, are not all over technology and social media. And so we are trying to use it as a tool with the understanding that, like, of course, if they spend all their time on the Háblame Bebé app, guys, like, listen, I'm here for it, okay, right? But our hope is that they use this as a tool. There's some functionality where they can add stuff, where they can move stuff in, like, right, and use it to learn and guide their ability to care for their babies and be their baby's first and best teacher. That is our goal. If they're only watching Háblame Bebé videos and developmental milestone videos, like, great. I guess we're like maybe going somewhere. My take would that be they're probably using this. Hopefully they're posting on social media. Hopefully they're looking at ours, and hopefully some of that sinks in to their interaction with their baby.
Yeah, I was not trying to take away from the app in any way, shape, or form. I see our families just kind of enamored with their phones, and I really worry about the impact that has on long-term development, especially with the information that you shared about how the early language makes such a difference later in life.
Thanks.
Stephanie, I actually have a question for you next in the chat. So Stephanie Napolitano was asking about the solutions for patient safety, asking, was this a time-limited SPS focus or project for an intention to restructure the way that SPS thinks about quality?
It's really the way we're moving forward to restructure and make sure we're doing the right thing. We've been collecting this baseline outcomes data for quite some time now. So to overlap it with the race, ethnicity, and language data, I think is such an important tool these days to make sure that we're doing the right thing.
Thank you. I actually have a question for Michelle. Michelle Marie Pena put in the chat about, NJC brainstorming about how we can share methods like this race and ethnicity data. And I'm curious to hear a little bit about folks' thoughts on like how, either, Stephanie or Michelle, about how we can teach other folks like about this, how to address this extremely common problem of difficulty collecting accurate race and ethnicity data for EFQI down the line.
So SPS does have a toolbox actually on just this. That was part of that work that I did with them. So they created some tools for people to use at other hospitals. So a lot of that information is right on their website and available if you need it. I can help you access it if you need that help too.
That's helpful, like background information too, to like start collecting and thinking about like how are hospitals approaching, what's, the standard, what's national standards, what's hospital standards, what are individual institutional standards. So really appreciate that. And we can always share that information if you send it to Stephanie Napolitano too about with NJC.
Yeah, and to add to that, I think it would be really interesting to use that toolkit. I'm not sure how disseminated that toolkit has been because so many groups I think are really auditing and trying to understand their own processes. And I feel like everyone's trying to reinvent the wheel at their own institutions. And so whether it be using that toolkit, adapting that toolkit, sharing experiences. I know Meg in Nationwide this is like her primary focus, and she's presented to NJC too on really trying to understand, these the other unknown and really improve the integrity of these data. And so these toolkits exist. I do think there's a bridge to implement. There's a gap in implementation, and I think some context considerations to take into account, especially in the NICU. And so I do wonder if maybe like an interest group, or as Ashley mentioned, like a task force, as we come up with like overlying topics of interest, might be something to consider in our NJC infrastructure to really foster that collaboration and people doing similar work in different places.
I think that makes a lot of sense. And coming from, our QI subcommittee leader, that's really helpful. Like that's the start of any QI project, right? Is having the data that's accurate to know where your gaps are. And so I think that's a fantastic idea. And Meg Barcraft had an amazing presentation for all those who want to view it. It's on our website, neojusticeclub.com, about her experience, at Nationwide, trying to make this process more accurate. And it's amazing how much work you have to do to make those types of changes. Want to give Ashley Darcy Mahoney a chance to speak to the other languages question a little bit more depth. I know it's a little bit of a not short answer.
Sure. So one of the questions was in the chat and that we get a lot is, are we gonna be able to replicate Habla Mi Bebé and Talk to Me Baby into other languages? And the short answer is maybe. One of the things we learned in the challenge grant was when we simply took the work we did with Talk to Me Baby and essentially translated it into Spanish with professional translators and all of the work we did on that, is it didn't resonate as much with families. Not surprising to like probably everyone that does this work here, right? Is that it didn't get across all the things that families told us it needed to. And that's when we did a lot of the iteration throughout the challenge grant. Once we had different funding opportunities to really iterate, change videos, add different cultural dialects, et cetera, et cetera, et cetera, to what families wanted and told us mattered and seemed to help. I think we'd have to do that with other languages and with other cultures in order to do that, which would also mean building a team of people that also know that community and that culture. Our team in Miami has strong Latin roots, or cultural pieces here that I think are important. The one group here in Miami that has told us they really want this is the Haitian Creole population and language. I think we have a lot of people here that could help us with that. We've worked with some colleagues in Ethiopia who are trying to adapt this entire program in the NICU in Ethiopia, working with their kangaroo mother care program. That is being really spearheaded by groups of people there. And so I think that's the part that I hesitate to say, like, whether my team or our team could do this, because I'm not sure we have, one, the resources. We have to apply for new grants to do this because it takes money, but also the right team. That doesn't mean we couldn't recruit the right team, but hard maybe. Not because I don't want to.
I think that's really wise, having partners who are very intimately involved with the community be the leaders in developing the app. And so I think that's really carefully thought out and wise. So but clearly folks want it. So there's a lot more work to do because it's such a great program and application. The next question I see is for Monica, about if you have a sense there's been more people applying to the NICU since the practicum recruitment was removed and bilingual applicants were encouraged to apply. Are there other planned strategies for increasing workforce diversity? Question from Ashley Vance.
So I don't have the NICU specifically data. I had a conversation with Donna before this talk because I don't work in the NICU, but she says that her diversity has increased, but she wasn't able to give me numbers. I can see as a whole for the new graduate program we do see our numbers like diversity. We are doing better at diversity through our new grad program by doing some of these interventions. And as a whole, BMC has a retention and recruitment council that does a lot of, I would say, outreach to many different schools. Here in Boston, we have a lot of community colleges, as well as a lot of community college associate degree and bachelor degree programs surrounding Boston Medical Center. I knew they do a lot of outreach there as well. So those are the things that they're working on currently. I hope that answered your question, Ashley.
Thank you, Monica. I just want to highlight a comment in the chat from Jamila Nightingale about, social work leaders in this field, that they're so focused on clinically making things happen that sometimes like publication of research is not the priority in social work, but social drivers of health and as a tool is so rooted in social work systems theory. And so she was highlighting about how we really need to bring in social work and have social workers lead us in some of that work. Jamila, do you want to add any more? You said it a lot more eloquently in the chat.
No, that's just it in general. And I'm also trying to read more on SDOH. So thank you, Ashley, for sharing that information.
Great. So I want to give another thank you to all four of our speakers as we conclude the end of this hour. I hope this was an opportunity not just to highlight, but celebrate the work of our nursing leaders who've done so much to advance our field. And thank you all for leading us in that effort. And I hope folks are as inspired as I am by all of these projects. And so the recording for this, we're hoping to be able to post it on our website, but we also want to be really, cognizant of like grants coming in and what the timing of that. So we may have a little bit of delay in posting this, but we definitely want to share with our friends. Our website is neojusticcollab.com. And also want to say that I misspoke earlier, those works in progress sessions we protect and don't record. And so the specific works in progress with Meg Barcroft talking about her EFQI efforts is not a recorded one on our website. So I apologize for misspeaking, but we hope to be able to send out this recording. And then reminder from Ashley Vance from the research subcommittee, if you know anyone who has a project or idea who wants to present for the works in progress session in August, please use the form to submit and we will welcome and have a great conversation about your project. So thanks everyone.
Thank you.
Have a great day.
Thanks. Great meeting.
Bye.